This week on the Wheelhouse. What Trump's big, beautiful bill means for access to health care and food. For Connecticut Public, I'm Frankie Graziano. This is the Wheelhouse, the show that connects politics to the people. We got your weekly dose of politics in Connecticut and beyond right here. President Donald Trump's sweeping domestic policy bill is now officially the law. His one big, beautiful bill provides tax cuts for some, and then it restricts access to health care and food benefits for others. This hour, we ask how these policy changes will be felt by Connecticut's residents. Joining me now, Andrea Barton-Reeves, Connecticut Department of Social Services Commissioner. Thank you so much for coming on.
Thanks for having me.
Thank you for coming on and coming into the studio. Folks can ask the commissioner a question about access to Medicaid, 888-720-9677, 888-720-9677. I want to ask you about your department and the work that you all are having to do now. You handle everything from Husky Health to SNAP benefits, child support services. What have the past couple of weeks been like for you, and how are you all doing?
It has been incredibly challenging, and I think everyone that works in the department, all of our stakeholders, all of our providers, everyone is feeling it. And the information comes at you like a tsunami. So when you basically have taken in HR 1, then something else comes, and then other things come, and then you then begin to unfold what is actually happening to people. And then trying to communicate all of this to everyone at the same time is also really challenging too. So we have our public who are very afraid of what's going to happen because Medicaid and SNAP are safety net services that we know people rely on in order to be able to feed their families and get access to health care. These are basic things. These are basic rights that people we know should have in order to live with dignity. So it's been extraordinarily challenging over the last 2 weeks.
So essentially you're unpacking the big, beautiful bill and having to worry about whatever comes down the pike in terms of a budget situation or a continuing resolution. Is that what you're trying to say?
That's right. We're trying to do both because we know that this is not the end.
So let's talk about the big, beautiful bill first and say that top state Democrats got together at the Charter Oak Health Center. I saw you there in Hartford recently for a news conference that you led. His sweeping domestic policy bill, President Donald Trump, slashed about $1 trillion or so from Medicaid, largest cut in the program's history. How big of an impact is this going to have specifically here?
So specifically here, we will be looking at what is known as our expansion population. And that's about 335,000 people who currently get Medicaid because we were able to do that under the changes to the Affordable Care Act and to the way that Medicaid works across the country. So there's a direct attack on those people. They are the ones that will be subject to the work requirements. So people, for example, who have been veterans who before would not have had to meet specific work requirements in order to get access to Medicaid, now they're going to have to work. For our SNAP program, the age for working now in order to qualify for benefits, has moved from 54 to 64. So now we have an entire decade of people who will now have to find work in an environment where work is really challenging because of all the layoffs that have happened at the federal level. And now people either have to work, go to school, be in a community program, or volunteer. We know that in this state, 73% of the people who are on Medicaid are already working, and 66% of the people who are on SNAP are already working. This is not an issue in the state of Connecticut. It might be in other states where, unfortunately, they don't have the same sort of density so that people can get access to services and supports and working. But that's not true here. But this is sort of a broad brush across the entire nation, and millions of people are going to go without health care. And many more people are really going to suffer, if not lose their lives, as a result of not being able to get access to care.
So you're concerned about potentially 140,000, maybe up to about 330,000 people losing their Medicaid benefits. But now you're telling me also that there might be more people that'll need benefits because of the fact that they're changing the work requirements.
Right.
So that number could be bigger in terms of the need.
It could be.
Yeah.
It could be much bigger in terms of the need. Our goal in trying to implement these work requirements, whenever we actually get guidance from the federal government as to how to do that, is to make sure that two things happen. One, that people are informed about their work requirements, whether or not they need to meet them in order to remain on or become eligible for Medicaid, and to help them do their best so that they can be able to do that, because we really don't want to see people fall off. In some ways, we've had practice with this, so to speak, with the unwinding after the end of COVID. So we know how to reach out to people. We know how to figure out who they are. We know how to communicate with them. But that work needs to start now. And the unwinding was a much more thoughtful process where we had more notice. This literally happened in a matter of weeks. So it's left every state scrambling. Fortunately, I would say we think we saw this coming. So we had been doing a lot of modeling and a lot of work beforehand. So we're more prepared than some states are.
And that's where I want to go, because there's only so much you could do to prepare when you don't exactly know what's coming. But you did do something to prepare. Help us understand what you did to prepare, and now I guess the response that you're having to do now. Just to help us understand some tangential things we could hold on to.
So one of the things that we did is we partnered with Yale University and the Tobin Center. They lent us a bunch of data scientists who are terrific and for free, which was also fantastic, so that we could actually figure out what the costs would be if, for example, we had to make cuts to Medicaid and if we had to have cost sharing in SNAP. And that allowed us to do much earlier what I think some states are doing now, which is to figure out, well, what would that look like? Who would we have to hire? What kinds of resources would we have to put in place? How would we have to change our systems in order to make this work? So we've had a chance to get ahead of that. We've also been able to talk to other states that have implemented work requirements like Georgia and Kentucky to understand what they've done so we can learn the lessons from them. So right now we can start hitting the ground with that work because we had a chance to have a long runway because we've been doing the work all along.
I want to know a little bit more about what happened in Georgia, because I think that is, as much as you can, because I know it's something that Yale put you onto, and you've probably been paying attention to a little bit in the news, but can you help us understand how the situation there in Georgia, and at least what you could learn about how some of these implementations are impacting people?
Sure. So in Georgia, it was actually their state legislature that imposed the work requirements. And so what Georgia decided to do was to implement an entire system where people could register and declare themselves eligible for Medicaid based on having met certain expectations regarding the work requirements. So not only do you have to register in the beginning, you also then have to determine that you're continuing to be eligible by meeting those work requirements. They did tell us it is a significant and heavy lift, and it's an expensive lift. And they're not necessarily sure that it's actually working as well as they would have liked because, number one, they had a lot of people who were already working that were on Medicaid. And the frequency with which they have to keep up with people to make sure that they're still working and having them report hasn't really resulted in more people working who are on Medicaid. It's resulted in more administrative burdens, but they've said to us, this is the way that the process works. And so here are some of the lessons learned. You want to design your system so that it makes it easy for people to self-report. You want to make it easier so that the people who work with you don't have to chase everyone down all the time. Maybe there are some lessons that they've also learned from unemployment, which has very similar rules to remain eligible for unemployment. So we're taking all of that in as we're talking to the vendor partners that we think we're going to be able to, will have to use in order to do this. We won't be able to do this on our own, just with state resources.
And there's the work you did with lawmakers too. So there's that
right.
preventative stuff that you've been able to do. There's the response. But also during the state legislative session, you all were able to get lawmakers to provide more money, more Medicaid dollars into the budget, and that's going to benefit FQHCs, the Federal Qualified Health Centers.
Yes. So that, I think, is really one of the biggest triumphs that I definitely credit the governor for and the work that we've done at the Department of Social Services. We saw early on, maybe in January, that if some of the things we heard, we thought would be happening to reduce access to care for poor and low-income people was going to happen, that we needed to shore up our primary care services. And that meant making a significant investment in our federally qualified health centers. And so that's what we'll be talking about today, later on with the governor. But it's historic because it's been at least a couple of decades since our FQHCs have had a significant investment of state dollars made.
It wasn't flat funded, but it was, might say nominally.
It was nominal and somewhat incremental, and not consistent, I would put it that way. So this deal helps to fix many of those issues, and we're really excited about that.
Let me back up in case people don't understand the acronym FQHC essentially these centers helped a lot of people during COVID. People might get their tests there. Charter Oak Center was one of the folks. I know that there was one in Torrington that my parents frequented. But help me understand what these health centers do and what they may have to do more of after the cuts come.
All right. So the health centers, there's 17 of them. They serve 440,000 people throughout the state. And they provide all forms of primary care that you can think of. Excuse me. And they also, for every age group that you can imagine. So you'll see pregnant moms come in, dads, children, everybody. Just let me take a sip here.
And we did see him as we were reaching out to you all as you had that news conference. Andrea Barton Reeves hosted a news conference. Senator Blumenthal was there. We also had Governor Ned Lamont there. John Larson was there as well, the congressman. Yeah. But you're seeing these people walk in and out as this is happening.
Excuse me. Yeah, so we see these people walk in. And there's just streams of people that come in every single day to get care because, as we know, getting a primary care appointment is really difficult. But at these centers, you can just walk in, you can get care, and you get really great quality care. So we knew that with what we saw coming down the pike, that more people would probably need care. And they provide care. They don't ask any questions about whether or not you have insurance, what your status is, nothing like that. So you're treated with dignity and respect no matter where you go to these 17 centers. And we're really proud of them. And we're lucky in this state to have a really robust network of federally qualified health centers. That's what FQHC stands for. And we're excited to have them. So to make this investment in them, I think it's historic, and we're thrilled to be able to support them.
Republicans have a different take. Head of the Connecticut Republican Party, Ben Proto, told News Channel 8 a huge portion of the Medicaid bill has to do with providing Medicaid programs and Medicaid benefits to people who are here illegally, who are using our emergency rooms as primary care facilities. Does what he's saying align with what you and your colleagues are actually seeing on the ground?
No, it doesn't. Our state, as we know, has made an investment, and it's made a decision, our legislature, to provide support to people regardless of their immigration status. And that is a decision that has been made, and we support that. And that's supported in part through the dollars that we use that are state-only dollars for people who are here undocumented and receive Medicaid. You can't receive SNAP, by the way, if you're not a qualified alien. That's the definition under the statute. So that's not true at all. I hear that often, and it's not the case. But that is a small percentage of the 440,000 people that go to the FQHCs. Most of the people that go are people who are here legally, but they can't get access to care because they don't have health insurance, because they work 4 jobs and none of those jobs actually offer health insurance. And if it does, it's a high deductible plan where you have to pay $20,000 before you even get a chance to access the care that the health insurance would cover. Those are the people we're talking about. So it's easy to get misdirected, I would say. And I understand it, and I'm in no way minimizing what Mr. Proto is suggesting, right? So I'm not being disrespectful, but what I'm saying is that's not the whole truth here. And I think we need to talk about the entire picture of healthcare in totality in this state and in the United States to really understand how this works.
It's a big talking point. I've talked to Stephen Harding, who's from Brookfield. He's a Republican. I talked to Vin Candelora. They're always talking who's the minority leader in the House. Thank you. And a lot of what I hear is that there's a Cadillac plan for these undocumented migrants. This is what they're always saying. But I talk about this because we had somebody from Georgetown who recently told us that one of the provisions that was previously in the bill was that states like Connecticut who do that, we take care of migrants that are undocumented migrants that are 15 and under, would get a big penalty from the federal government and lose dollars for Medicaid in the big, beautiful bill. But I understand that was taken out.
That was, yeah. So that wasn't a part of the bill. The penalty would have cost the state about $250 million, right, for covering about 15,000 people. So it would have meant that we'd have to make a really difficult decision about what to do. But fortunately, that was not a part of this bill.
Here's a big thing to kind of wrap our heads around here. Even if you don't get cut from Medicaid and you still have coverage, could your costs still go up? Your cost of care?
So yes, the cost of care will still go up because you're still going to need more people who are going to need care. with the work requirements specifically, and I know we keep returning to those because that's really the biggest impact, there will be more people who will fall off of care. So our total cost of care, not just under Medicaid, but people who don't now have any insurance will still seek care. So that means that they'll be going to hospitals and emergency rooms, regardless of their immigration status. And now we're going to see a significant increase in the number of people that will go. And all care has to be paid for. We know that. So then what does that mean? What does that mean to the way that we compensate hospitals and providers and primary care physicians that are unaffiliated with hospitals? It means a lot of costs across the board.
What's the timeline? Are states required to implement changes right away? Like how should we look at this in terms of when it's really going to start to hit us?
Right. So the Medicaid changes are going to start to hit us in 2028. That's when we have to actually be compliant with this rule. But the work has to start long before that in terms of education, the systems and training, all of that has to happen. So we're ready for 2028. The SNAP changes, though, those will happen right away because those were upon implementation. So that means now we have to figure out how to apply the work requirements for the SNAP benefits. For those, as I said, the age range is now up to 64 from 54. SNAP has always had work requirements. Now they sort of match the same work requirements that are in Medicaid, and that starts now.
Oh, man. I hate to ask you this question because I don't know if you're exactly ready for it. You're as ready as you can be for it, but I know you're doing all the work. Do you understand how much in total we're losing from the federal government, how much the state can backfill? And because the question we're going to want to ask is how much money is the state going to be able to provide to kind of fill in the blanks?
Right.
So how can you help us unpack or at least detonate that atomic bomb I just threw at you?
I think that's a good way of describing it.
Help us understand where we got to go, I guess.
Right. I think that the governor and the legislature will eventually decide where we have to go. So every state agency, there are many state agencies beyond DSS that are going to be impacted. So we're talking public health and education and the Department of Mental Health and Addiction Services. I couldn't sit here right now and tell you what the entire picture is. I know that for now, we're going to have to fill the gap for people who will be dropping off. So there might be an opportunity to provide a fund for uncompensated care. I have no idea what that's going to look like. I know that filling in the gap for the SNAP benefits, because now we have to pay up to 75% of that. That's going to be between $30 and $45 million. There's also a penalty for us having what's known as a SNAP error rate above a certain percentage. Right now, we know that number is about $145 million. So just those two alone under SNAP is going to cost us, $200 million in perpetuity, right? And so there's no state that I know of that has those kinds of resources in perpetuity, no matter how large their rainy day fund is. So that means that we have to redesign the ways that we provide Medicaid and redesign the ways that we provide SNAP so we can stay within our available resources and hope that we can still provide support for people when they need it.
But I guess the nuance that I'm going to have to drive at now after talking to you is that kind of it's going to be a moving target now, because I go back to what you said earlier about the work requirements changing and more people potentially having to rely on Medicaid in the future. So this is kind of going to be a moving target because you're going to, especially with the way that the economy is appearing to be right now with costs being so high, you're anticipating that more people are going to need SNAP and Medicaid benefits, but there's only so much that you can do. So it's kind of a moving target, I guess.
It is a moving target. We see more people now, right? We see already, even before this bill passed, that there was an increase in the number of people who are applying for Medicaid and SNAP. It is overwhelming the limited number of people that we have that actually engage in eligibility determinations because the applications just keep coming in. As food goes up, as rent goes up, as just the cost of living goes up generally here and across the country, we're finding that more people are finding it more difficult to make ends meet, and so they need to rely on SNAP and Medicaid. Even with two-parent households with both parents working 2, sometimes 3 jobs, it's still very hard.
I'd like to close by trying to get some perspective from you. In doing this work for over 20 years, just kind of help us understand the current moment and how you feel, how it might feel different compared to any other time that you've been working here and dealing with the situations.
So the current moment feels as if those who are poor and low income, who are working hard to create good lives for their families, are really being targeted because they are poor and low income. there are many, many, many more poor low income people in this country than I think people want to think. There are lots of stereotypes about who they are, what their work ethic is, what they think about the work that they do, and the I guess the advantages in education and things that they have deliberately made decisions not to take advantage of so that they are where they are. So there's a lot of blame of people who are poor. But you can't blame 144 million people in the United States who are poor and low income. That means that there's something structurally different about the way that we see wealth and wealth inequality as opposed to an individual responsibility. I'm not saying that there isn't in many circumstances, but it's not the totality of the circumstances. And I think I feel very sad for us because that's not the only narrative that can be spun or shared around what poverty and low income really means. We've always lived with it as a nation, but it's really never been anything that looks like the way it does now.
And just for further perspective, how much money does a family of four need to live in this country about?
In this state, you need $116,000 to meet your basic needs as a family of four.
So one question might be the Alice report, which is always important to look at. That's United Way of Connecticut.
That's correct.
So one thing that you may be able to do if you're at home is go in front of a mirror and ask myself, do I live in a household where, especially if you have children, do I live in a household where we have at least $116,000 that we're making? So that's a good thing to say, because you're saying 140 million people in America are in poverty.
That's right.
It's about a country of 350 million people. So that's just basic math. But this has been a tremendous conversation. I have to let you go, but I've been having a great time.
Thank you.
Thank you to Andrea Barton-Reeves, the Commissioner of the Department of Social Services. Thank you so much for coming on the show.
Thank you. Appreciate you having me.
Thank you. After the break, we zoom in on one especially vulnerable group, cancer patients. We want to ask what care may look like as President Donald Trump's domestic policy bill takes effect. You can join the conversation, 888-720-9677, 888-720-9677. Stay tuned for more on The Wheelhouse. This is The Wheelhouse from Connecticut Public Radio. I'm Frankie Graziano. On the 4th of July, President Donald Trump signed what he calls one big, beautiful bill into law. This hour, we're looking at what this bill means for Medicaid and SNAP recipients in Connecticut and beyond. And joining me now is a good personal friend of mine, who, of course, is my colleague, senior health reporter for Connecticut Public, Sujata Srinivasan. Good morning, Sujata.
Morning, Frankie.
If you rely on SNAP or Medicaid benefits, we want to hear from you. What do you think of the recent federal funding cuts? Call us 888-720-9677, 888-720-9677. Sujata, oftentimes when we think about Medicaid and healthcare coverage, we think about annual checkups, the cost of care, maybe coughs that just won't go away on their own. But your recent reporting centered around care for a much more vulnerable population, breast cancer patients. What do we know about cancer treatment and Connecticut's Medicaid program?
So, Frankie, yes, we do think about annual checkups, but people are living longer, and we are seeing a rise in chronic diseases, metabolic syndrome, heart, stroke, diabetes, and cancer. So there are estimates. One from the University of Chicago points to a 30% surge in cancer diagnosis rates between 2019 to 2030. So that's where we are going to see an area of strain on finances. And the way I look at it as a health journalist is we have many decisions coming out of the federal government, and this big, beautiful bill impacting various people on Medicaid. And it's like eating a chocolate elephant. Like, how do you approach a chocolate elephant bite by bite? So we looked at cancer. I looked at cancer because the day the Senate passed the bill, I happened to be meeting the head of oncological surgery at Smilo. And she was concerned deeply, and she spoke about people potentially dying due to lack of access and lack of care. So that's how this story evolved into covering cancer care. But there's going to be a lot of other chronic illnesses covered too that I'll be looking at.
Lack of care, lack of access to care. I imagine that there's a mental health sort of problem that springs from that, is that you're understanding that I may not get access. I may not be able to afford it. So does that really impact a person's willingness to seek care?
Yes, I mean, data shows that people do not seek care. They do not even go to a doctor if they know that they can't afford care. Right now, Connecticut is spending about $615 million in cancer care. That's according to claims paid out by Medicaid, and this is Medicaid data in 2024. And that comes to about $42,000 per head. Treatments are getting expensive, especially immunotherapies, and we're also seeing that younger people under the age of 50 are being more increasingly diagnosed with cancer. So there's a cost element there. And just imagine, several $1,000s for a chemo infusion. And these prices haven't gotten cheaper after hospital consolidations, even nonprofit hospital consolidations. So chemotherapy, and then we're looking at prescription drug prices. We're looking at things like childcare. When you're not able to work with cancer, then how are you going to pay the rent? I mean, all of it amplifies. And then there is the medical component where I'm looking at data from research and doctors telling me that stress, the burden of stress, the financial toxicity, as the term was coined, itself can contribute to worsening cancer outcomes.
I know you're trying to understand how we're going to be impacted in terms of Medicaid coverage and all of these changes that are happening in the big, beautiful bill. What do we know about work requirements and how that's going to impact cancer patients?
Yeah, see, 1 in 4 people in Connecticut are covered by Medicaid, compared to about 1 in 5, because we are one of the 41 states that expanded Medicaid under the ACA, Access Health. So now, work requirements. I mean, there's enough and more data, including from KFF, that shows most people on Medicaid work. They work low-end jobs. They have multiple jobs, and they work for employers that do not provide insurance. And when people have either high deductibles or they don't have access to employer-sponsored insurance, I mean, these are people that rely on Medicaid. So they're already working. The work requirements now are about, it's exactly 80 hours per month. But
80 hours per month,
can be broken down in different ways. So it's community service. If you're a student, then you have to show that you're, doing, some sort of studies. And all of this is going to drive up administrative costs. It was a failed experiment in Arkansas. The renewal frequency is now 6 months from 1 year. And data shows that 18,000 people in Arkansas lost their Medicaid insurance in a span of 4 months, Frankie. It did not work. These work requirements, most people don't even know they're on Medicaid because each has got a different name. In Connecticut, we call it Husky. So then to educate people, to let them know that these are the work requirements. I mean, these are people juggling multiple jobs, juggling childcare. They don't have transportation to get to work. So now they have to show every 6 months that they're looking for a job or they're employed or this is happening. And the administrative burdens, delays in websites being down, delays, and people just drop off care. People just don't want to deal with it anymore. There's just too much going on in their lives. And then the Arkansas experiment showed that not only did people lose 4,000 people in 4 months, lose their insurance, Medicaid insurance, it had minimal to no impact on increasing work rates for people under Medicaid. And then a court had to strike that down. So this, at a national experiment, is a failed national experiment, and that is what we are now implementing nationwide.
But the work requirements are designed to sort of wean people off of Medicaid, so that people won't need Medicaid anymore. That's what they really want to do. They don't want people on Medicaid.
Well, I mean, when people are working low-end jobs and they're working 3 jobs, and if your employer does not provide insurance and the deductibles are high,
and you only have 4 months to be on Medicaid,
it's going to increase uninsured, the rates of people who are uninsured. Data already is projecting that in Connecticut and all of the states which had expanded Medicaid access under Husky T. I mean, we're going to see a significant increase in the rates of uninsured people. 3 percentage points at a cautious estimate, and various other estimates for various other, looking at other data.
Yeah, you're talking about people going through these requirements and having to juggle all these things to keep their Medicaid. and they may be juggling a cancer diagnosis or treatment. Are there any forms of financial assistance available for cancer patients that you guys have been turned on to outside of the traditional support through Medicaid?
Well, the first point of contact would be the federally qualified health centers, regardless of insurance, regardless of immigration requirements. So now under the big, beautiful bill, refugees, asylum seekers, victims of trafficking will not be eligible. They would be phased out over time. But everybody is welcome to a federally qualified health centers. Many of these people that I listed, these categories of people do work. I mean, they work on farms. They might provide domestic labor. So they're providing some sort of work. So the federally qualified health centers is one place to go for primary care access. And then for uninsured, the Connecticut Department of Public Health has a free program. And for people who are financially eligible, it's the Connecticut Breast and Cervical Cancer Early Detection Program. There's an age and an income eligibility for that. However, if, let's say, a mammogram says this person might need a biopsy, that would have to be covered by Medicaid. And if they are not on Medicaid, then we have to figure out where these people can get care. There's direct hospital assistance and then community nonprofits, which provide everything from driving someone to their appointments, providing childcare, even assistance with household work, electricity bills. But people would have to... There's an awareness campaign that Yale is now launching to reach these people, to let them know they're not alone.
Through Yale University, you spoke with one woman, Deltra James, about her experience fighting cancer. Here's a clip you gathered from that conversation.
When I had to have a lumpectomy or the infusions that I've had to sit and endure, and every time I'm in that chair, the thousands of dollars that it costs. I had other things to think of, like childcare. I have 5 daughters.
That photo you're seeing, if you're watching the stream on youtube.com/Connecticut Public, is really the face of what we're talking about. You said it earlier, among all of the things that you're having to do sometimes, if you have a cancer diagnosis and trying to be able to afford care, you're also trying to afford child care. This is somebody with 5 daughters. She's talking about what cancer does to you and then the financial toll it takes from you, right, Sujata?
Exactly, and she said Medicaid saved her life. And that's what she told me. We had a long conversation. She said, Medicaid saved my life. And she was working, by the way, at a call center. She was working out of home. She was employed. And then she couldn't work during her diagnosis. She was diagnosed when she was 33 with an aggressive form, stage 4 triple-negative breast cancer. Something that is potentially, when Black women, younger women, are diagnosed at higher rates of triple-negative breast cancer, much later stages. But she was working. And I've spoken to social workers, including Yale social worker. I spoke, to one of them who said, look, a lot of our cancer patients, in fact, most of our cancer patients work when they come to us. They work low-paying jobs. Kristen Madrid told me that. And they stop working only when they receive extensive chemotherapy, immunotherapy, and their bodies cannot work.
Yeah. I want to expand upon this a little bit, this conversation. Deltra James is a Black woman. Other women of color, more broadly, how are they uniquely challenged? You talked about the unique challenge that they face, but at least in terms of this bill and how it passed, how is it exacerbating the crisis?
Well, the bill is in the context of many other federal decisions, including NIH funding cuts. It's pulling back on diversity research. I've spoken to researchers at UConn, at Yale, who talk about the new grant proposals which they're not even submitting if there's a diversity element. Clinical trials, for example, would need to be broad and diverse because, as we all know, Americans consist of many races, and every racial outcome and disease progression depends a lot on biology, in addition to socioeconomic factors. Talking about socioeconomic factors, I'm going to digress just a little bit. There's data to show, and I reported on that our Medicaid expansion here in Connecticut went so far as to, and there's a JAMA study pointing out that eviction judgments came down after Medicaid expansion in Connecticut. So when we talk about the socioeconomic impact, people living in poverty, what having healthcare can do to these people. So how is it so unique in terms of disease progression and access? So one are access barriers, and the other, Black women are 8% less likely to be diagnosed with cancer than white women, but 12% more likely to die if they are diagnosed. And that's according to the American Cancer Society. A lot of it has to do with socioeconomic access. And also Black women under age 50 are twice as likely to die of breast cancer than white women. So like I said, the funding cuts, the diversity cuts, the NIH cuts, and now the shrinking of Medicaid available, the access to treatment, the access to early screening, preventive screening, as Dr. Greenup was worrying about. Now that's everybody is going to take a hit. Everybody, even those people not covered by Medicaid, everyone's going to, because the cost has to be shared. Nothing is free. There's no such thing as a free lunch. Somebody has to pay for it. So the cost burden is going to be shifted around. 1 trillion potential Medicaid cuts to support 4.5 trillion in tax cuts.
You mentioned that you're going to continue to follow the impact of the big, beautiful bill in your reporting, in your health reporting at ctpublic.org and on the air, Connecticut Public. What are you going to be looking for next? What kind of string are you trying to pull? Or is there anybody that should be reaching out to you specifically?
So I'm going to look at equity, like who's impacted in terms of equity. I'm going to look at various chronic disease populations. Going to look at rural hospitals, how they are going to be impacted, how staffing is going to be impacted, reimbursement rates affecting staffing, affecting long-term care, especially nursing home care. I mean, this is broad and deep and vast.
You've been listening to Sujata Srinivasan, senior health reporter for Connecticut Public. Sujata, thank you so much for coming on the show.
Thank you, Frankie.
I appreciate it. It was good to hear you and see you. ctpublic.org for more of Sujata's health coverage. After the break, President Trump's sweeping domestic policy agenda calls for the largest cut in history to the Supplemental Nutrition Assistance Program, or SNAP. Take a look at what that means for families in Connecticut. If you have a question about SNAP benefits, give us a call, 888-720-9677, 888-720-9677. This is the Wheelhouse from Connecticut Public Radio. I'm Frankie Graziano. 1 in 8 Connecticut residents struggle with hunger. That's according to End Hunger Connecticut, a statewide anti-hunger and food security organization. That's where SNAP comes into play, the Supplemental Nutritional Assistance Program. Many families across the state rely on SNAP benefits to access food. But President Trump's recent bill will slash funding for SNAP, the biggest cut in the program's history, according to the Associated Press. Joining me now to unpack exactly how the program will impact families across the state, Amari Brantley. Amari is a policy coordinator for End Hunger Connecticut. Amari, thank you for being on the show.
Oh, thank you for having me.
So happy to have you on.
Super excited to be here.
Folks want to give us a call, 888-720-9677 if you have a quick question about your SNAP benefits. Hey, how many people in Connecticut rely on SNAP benefits about?
So in the state of Connecticut, we have about 400,000 residents that rely on SNAP as of our 2024 data.
And you're thinking that 34,000, maybe even more, could lose their SNAP benefits based on the big, beautiful bill and its passage?
Definitely. So looking at our statistics as of yesterday, when prepping for this meeting, we saw that between 34,000 and even up to 110,000 can lose their SNAP benefits, at least half or all of their SNAP benefits going into 2027. And looking at what that looks like with the work requirements and everything that could possibly or will be put on or put forth with this big, beautiful bill, we just see that direct impact on Connecticut residents.
What are lawmakers telling you about whether or not they'll be able to pay for that? If all these people lose their SNAP benefits and the state has to backfill it or somebody does, are you understanding how much money they're going to be able to put forward to do that?
So
to make up for like a shortfall?
So a shortfall, we recognize that the state of Connecticut receives about $1 billion in SNAP funding on a yearly basis. And so with that, the state would initially have to cover about 15% of that, looking at that being around about $150 million. And so understanding that we do have the $4 billion rainy day fund, but still looking at the entirety, that's $150 million that we would have to cover in SNAP funding. Can the state even handle that, right? No state has ever successfully taken on the entirety of SNAP funding for a state. And just looking at the amount from just 15%, we can only imagine if the state had to cover that entire $1 billion cost.
I'm having to ask this about a lot of things: Medicaid, education funding. So it is easy. You just brought up the $4 billion figure, and I do this all the time when I talk to the governor. But it's easier to understand in totality when those costs start to pile up how hard it is to actually backfill. So that is important information. But you still will be looking to the state to try to backfill as much as they can for the cuts. President Trump's funding cuts, how does this impact students? These SNAP cuts, how does it impact students, particularly kids in elementary schools?
So specifically here in Connecticut, we have around 500,000 students. We have this bill will affect them in multiple ways, but one way, looking at direct certification, where over 130,000 students are directly certified because of the related practices of SNAP and Medicaid, and to which we see that those students receive free school meals. Here in the state of Connecticut, we recognize that there are 206 school districts who are on what is known as the Community Eligibility Program, which is a federal provision where if you have a 25% rate or poverty rate or above, then you may receive a federal reimbursement for a school meal, right? And so we see cities like Bridgeport, New Haven, Hartford, and Waterbury, my hometown, that get full reimbursement for CEP meals. But we see it an entirety of a bunch of other cities that are on the CEP program. And then we see cities like Stamford, who being a part of the CEP program actually lose money with that federal provision. So we see that strickening coming down to looking at those districts possibly having to fulfill all or losing some of those numbers, and now seeing, do they stay above that 62.5% ratio, which is required for every student to get a free meal. And so then the occurring of school meal debt and other entities like that occur because we know children, even adults, cannot survive when they're hungry. Looking at children every day when they wake up and go to school, I'm sure when you were in school, and I talk to my mom about this all the time, she says, even if you didn't have the lunch money in the line, you were still able to maybe get a ham sandwich or a grilled cheese sandwich. And right, so now who receives that debt on the backside for when student meal debt gets to that certain ratio without students being able to afford it? And then we look here on the second side where we see reduced price meals, which is a big thing here in the state of Connecticut, which we offered free meals up until 2023. And then we saw a huge decline when we offered strictly free for reduced price meals, which now is no longer free here in the state of Connecticut. So we see about another 80,000 students losing access to that free calendar, especially in a time where the working class poor and individuals like that, for a family of four who make more than $57,000. We see that touching students in school as well from these federal provisions.
It's a tough summer for that mom that you're talking about, because at the same time that they're thinking about these potential cuts that are coming, you're having to provide a meal for your kid every day for lunch, potentially, because it's the summer. So help us understand about summer EBT. What is that, and how will funding cuts impact that program?
So Summer EBT is a program that was put forth to assist families who are eligible for school meals or eligible for SNAP. They get possibly an increase. In Connecticut, it's known as SunBucks. And so it's a really big deal because families here are able to get that assisted grocery help when their children are at home during the summertime. And we see that this can be held up not only with educational grants, but agriculture grants in another way, where we see a huge reduction with this big, beautiful bill, and especially now changing the requirements to not only SNAP, but how does that make families eligible? If we look at, I believe, summer 2024, there were 330,000 families that were eligible for SunBucks. And if we change these requirements, while these requirements are being changed, we now see that that could drop drastically. It could even go from 330,000 to presumably 175,000, and look at how that's been cut in half, right? So now half the families that need these sunbucks or need this assistance may not meet the requirements, and that means half of those children possibly could go hungry, right? We recognize that specifically of the 400,000 people, 67% of those households have children in them, right? Another 37% of the 400,000 have people with disabilities in them, and how it all intertwines.
One reason you may want to have food provided for these children is because they may want to go to school because there's food there.
No, yes. Well, we looking back into the data for 2020 or since 2020 when school meals were free, when we look at October 2023 to October 2024, 3 million less breakfasts were served at school. What number also jumped was attendance rates. When we looked at attendance rates between that year, they simultaneously had a downfall matching the school meal. So we could basically add it up to say families were advocating and pushing bringing their children to school, not only on time, but bringing them to school in totality because they would be offered a meal that, may do it. We look at cafeterias are the biggest restaurants in the world. And we see how they affect students every day. And for certain students, that's the only nutritious meal that they get. And so we understand how important it is for school meals to be in at school, and we hope.
Just quickly to kind of put in perspective something you said earlier about the $150 million in cuts that we could experience and having to backfill that. Big news recently was that food pantries in Connecticut secured $9 million from the state, which is way more than is the annual $850K or so that's allocated. But you're trying to square that $9 million with that potential $150 million shortfall.
No, yes, we can see with the loss of NFLSIP funding and NFLSAP funding, we see that the state of Connecticut, and we're very happy that the state of Connecticut was able to backfill with that $9 million. But we have to think about the 15, 20, or 30 million that that organization or those food pantries have lost, right? We have to look at it in terms of the types of meals, right? How many meals can we count that are no longer on the tables for family and residents of the state of Connecticut that need it, right? Earlier, the commissioner stated, we're seeing and witnessing an attack on poor and low-income families here in the state of Connecticut. And those are some of the families, and those are some of the major factors that assist those families. And by losing that, we can see that can have a detrimental price range of much more than $9 million.
We have less than a minute for you to do this for me, but just help me understand what's next with all of that in mind, with such a shortfall ahead of you all. What's the message that you could make to lawmakers? What can you tell people? What are you going to do over the next couple of months?
That SNAP matters. So over the next couple of months, we'll be leading an advocacy campaign on the state level, on the federal level, and we'll be looking for other advocates to join us, recognizing that SNAP matters and that at the organization End Hunger Connecticut, we want to continue to fight to end hunger on all racial standards, on all base standards for residents in the state of Connecticut and in the world alone, in the entire world.
This is Amari Brantley, Policy Coordinator for End Hunger Connecticut. Amari, thank you so much for coming on the Wheelhouse.
Thank you.
Today's show produced by Chloe Wynn, edited by Patrick Scahill. Our technical producer is Dylan Reyes. Download the Wheelhouse anytime on your favorite podcast app. I want to also thank our visuals department here at Connecticut Public, our operations department, Vanessa De La Torre and Megan Fitzgerald, and everybody else who helps out on the show. Thank you so much. I'm Frankie Graziano. This is the Wheelhouse. Thank you so much for listening.